Okay, I think people are going to be hopping in and out, and we have so much to get started. So, welcome. It's your favorite time of the month. It's the Download MyHin's monthly webinar diving into the intersection of healthcare and technology. I'm going to put on my video for now, just so that you can see I'm like a real person. I'm so real. It's annoying, actually. Here is our agenda for today. Today is a dream come true for me. I know I need to get a life, but you guys, I'm so excited. I'm going to start off with telling you a little bit about MyHin and why I think we're here today. But you tell me why we're here. Come on, just tell us all why you're here. What do you want to know? Then I have the real pleasure of introducing Kelly Cronin, the Deputy Administrator of the Administrator for Community Living from our Federal Health and Human Services. Then I will be introducing our panelists and our facilitators, and then I will be quiet while our panel and facilitators dig in deep on the questions you want to have answers to. And then we are going to be counting on you for some dynamic discussion. We want it all. Come off mute, come into chat, write me messages, SOS, send your owls. Let's get started. Thank you. Today, you are here for our social care, interoperable referrals, community of practice panel. You are here to see care advisors, care convene, find help, Hold On, PCE systems, Riverstar, and WellSky, along with 211 and MyBridges. This is an action-packed day, and we have like the heavyweight. We've got the heavyweights here. So thank you for being here. A little bit more about why MyHin? What is MyHin? You are here, you are at MyHin's convening. MyHin is the state's nonprofit entity for exchanging health information. We are collaboratively governed, and we serve as a backbone infrastructure for health information exchange. We receive 400,000 unique provider health information from 400,000 unique providers, labs, pharmacies, health plans, and other community stakeholders. We match it to the appropriate person across disparate source systems. We monitor not only who needs the information, but who is authorized to access it, and then provide it securely and privately to authorized users. We believe that in addition to our technical utility, having a neutral steward of data, not wholly owned or controlled by government or by any one sector, is critical. Next slide, please. I'm turning off my thing. Okay, so my name is Joanne Jarvie. I am the Senior Director of Outreach and Market Communications for MyHin. And communications is defined by the successful conveying or sharing of ideas. To me, communication is at the heart of being a human being, and successful communication is kind of hard to come by these days. As we move through this convening, and for most of the webinars and meetings that I facilitate, I really try and get everyone here to remember to focus on human infrastructure, okay? We are technological infrastructure. What we do is technological infrastructure. But if you want to talk today about the hows and the whats, and you really want to get into it, this is not going to be your meeting. I am happy to introduce you to our program managers and our product developers and all of our engineers, and they can really get into it with you. But today, we're going to focus on how technological infrastructure can support human beings. We're going to be talking about the whys and the whos, and not the whats or the hows. And the reason that we're doing that is because if we align on whys and we know who we are, trust can begin to be built. And if we have learned anything over these years, it's that this work, what we're talking about doing here, will only move at the speed of trust. So why does MyHin exist? Signed into law in 2009, the HITECH Act required health systems to implement the use of EHRs. And at that time, there was no requirement to standardize EHRs to ensure the data could be shared between different electronic health records before they were widely adopted. We evolved as a solution to data silos that emerged among hospitals and health systems and the variety of health electronic record software they implemented. We exist to provide a shared technology infrastructure for the secure, private, legal, digital exchange of clinical data to help improve the health of Michigan's people. People are not just slices of data. They move, they grow, they travel, and hopefully they have different care teams. Next slide, please. So we were created to solve for a lack of coordinated care and efficient systems, and to support a streamlined delivery of care to improve health outcomes. Interoperability between systems supported by infrastructure means codes and wires and pipes. Okay, it's what makes banking work. It's what makes GPS work. We're trying to make it work for critical health information too. Next slide. MyHIN operates as an information hub. We send and receive or exchange patient health information from many different EHRs and technology platforms, so that primary care practices, emergency departments, pharmacies, health insurance companies, public health can quickly access and share critical health data in real time. The more entities connected to us, connected to the network, the more information they can all access, and the greater value we can bring to all of our participants. The collection of this data can offer insights into population-wide health trends for greater public health awareness and more effective health monitoring and resource allocation. Next slide, please. So that's a little bit about MyHIN. I did it fast because it's boring. You guys are here to talk about social care interoperability and to meet these community of practice leaders. A little bit about why MyHIN is here and why we are so proud to be facilitating this group and this convening today. Next slide. So Michigan has been on the leading edge of a lot of work regarding social related health needs and social determinant of health interoperability. In 2015, the Centers for Medicare and Medicaid Services awarded Michigan $70 million over 4 years to test and implement an innovative model for delivering and paying for bringing together health-related social needs and social care providers in the community that could help those needs. Social determinant of health referral and data exchange platforms came into being, not just in Michigan, but around the country to support these models. But again, silos present challenges. So we see on this map, we see the area agencies on aging that we've worked with. We see these shires that were created during this as innovative health regions. We see our patient-centered medical homes and our pathway community hubs. To support more interoperable social care infrastructure, next slide, please. In August of 2021, MyHIN convened vendors, care advisors, FindHelp, PCE Systems, Riverstar, and WellSky together, and they created the Interoperable Referrals Pledge. But look, so a pledge is a pledge. I pledged like not to talk so much, and look, I'm talking, but a pledge is just a pledge. And so where is the action? So what? So you say this stuff is important, like where's the rubber going to meet the road? Next slide. The rubber meets the road. Building off of momentum created by our Interoperable Referrals Pledge, 8 of the nation's leading social care platform vendors, care advisors, CareConvene, FindHelp, Hold-On, PCE Systems, Riverstar, and WellSky performed a community of practice. Action, not just words. Collaboratively governed and facilitated, this community of practice is dedicated to the statewide sharing of data that documents social needs identification, referrals, interventions, and outcomes amongst care teams that span health and social care. The organizations collectively created a charter and defined their practice as a group of people who share a common concern, a set of problems, an interest in a topic, and who come together to fulfill both individual and group goals through the sharing of best practices and creating new knowledge to advance a domain of professional practice. They share a singular focus and a shared mission of improving people's lives by supporting community-led systems of care. Each respective organization has committed considerable time energy, human capacity for public benefit. In the same way that trust must be facilitated between a patient and a provider to adequately and accurately capture the whole picture of a person's health, so is the community of practice working to foster trust between each other, between health, between social care provider organizations, and between the clients and humans and patients that we serve. Next slide. Here to tell us why she's joining in is Kelly Cronin, Deputy Administrator, Innovation and Partnerships at a Health and Human Services Administration for Community Living, otherwise known as ACL. We are so excited to have Kelly Cronin. Kelly, please come on, tell us why you're here. Tell us what you want to hear about. Why is the federal government interested in what we're doing here, do you think?
Well, thanks so much, first of all, for just including me in your meeting today. And it's great to see all the progress, both through the pledge and this community practice. And I, the short answer to your question is that, there's just so much recognition now for a number of years, but it's even more so in the last couple of years around the needs to address social drivers of health and health-related social needs, and more specifically, the need to be really deliberate in integrating health and human services. So, whether it's at a state level in Michigan or at a federal level or, other state community level, at all levels, we need to be doing our best to align care and services for individuals, particularly those most in need. And it's going to be sort of an ongoing collaboration to figure this out because of the complexity of so many of the policies and programs and just the reality of everything that's going on today in the market. But we've, as ACL's been a big part of sort of the HHS effort to figure out, well, what is our plan? How are we going to integrate health and human services? And in large part, because as a human service agency, we've funded the Aging and Disability Networks for many decades. The Aging Network was authorized under the Older Americans Act, just when Medicare and Medicaid were authorized since 1965. It's always been a part of our authorizing statutes to do information referral to serve these populations, the older adults most in need. There's incredible capability at a community level to leverage. And so we've been very vested in this process.
No, what needs to happen is they might have room. We're moving.
We're very invested in this process because there's just so many important community-based organizations across the country, 20,000 organizations that are part of the Aging Services Network. And they have incredible depth and expertise and programs and services and a workforce that needs to be further developed. So when we sit at the table of HHS or at meeting with other organizations like the ones you all are part of, we have that lens of let's not forget about our community assets and let's build on them because they are the front lines of serving these individuals that we all want to serve. So first and foremost, we are in this because it's all about these individuals that need these services, that are food insecure, that have housing instability, don't have access to transportation, that are socially isolated, that are not mobile at home. There's so many needs and finite resources, especially on the social services, human services side. We need the infrastructure to braid the funding to be able to deliver these services. We need the healthcare partnerships to create a system of care that is more seamless, supported by a lot of the companies that you represent, but it's ultimately about the individuals and us working together to sort of create that more interoperable, integrated system, but in a way that really leverages our community-based organizations and doesn't disintermediate them. And so I think we have this real opportunity in front of us to sort of take a step back after a few years of a lot of rapid progress, right? Like many of you have been in companies that are fast growing, lots of resources being, pushed into your companies, great fast growing market share, but not always a lot of time to think, okay, well, here's this group of gravity projects, standards or US core data on interoperability and an implementation, FHIR implementation guide. How do we implement that? So there's the take a step back to take into account, how do we collaborate for interoperability, which you're already doing, but it's also, let's take a step back and think, are we really engaging our community leaders in a way that they are part of co-designing this system of the future, that they are being empowered because many of them have been in this for decades, all about serving these individuals, so much expertise, so much awareness of the community need, and an incredible workforce and programs to be able to deliver. So I think it's really important for us to be very deliberate about who's involved with these collaborative processes and making sure that we're bringing our CBO leaders to the table with healthcare leaders who want to invest. It's great that we have health systems that are going to be more routinely screening for health-related social needs. CMS policies and regulations are reinforcing that with having new screening measures and positive screen measures that all health systems are going to be doing over the next couple of years. Same with special needs plans, like that growing expectation for healthcare to be screening for health-related social needs could be leading to a pretty significant increase in referral volume. But what happens post-referral? Where's our community infrastructure? Where's the support and the referral networks that really ideally should be managed by the experts that really know the community, that really know the community services, all the CBO partners to be able to address this spectrum of needs? Because I think many of us know that there's great research to show that it's not that, for example, older adults, Medicare, 2 million Medicare beneficiaries in Michigan, 50% of them have some kind of health-related social need, but another 26% have multiple needs, right? So you need not just a referral to get a home delivered meal if they're food insecure post-discharge at a hospital, but you need to really be looking at them in the home and doing a full assessment and getting them connected to transportation or respite services. There's a whole spectrum of needs often that you uncover when you do a deeper assessment. So really important to be able to leverage the existing community workforce in understanding those needs and being able to be working with healthcare post initial screen that maybe a discharge planner or somebody in a primary care practice has time to do, but the really thorough, deep assessment is often within the community where people really are trained and do that day in and day out as a part of an intake process. So all this is to say, things are changing quickly. The policy environment is really changing on a federal level and increasingly through Medicaid and other opportunities. It's happening at a state level too. We have unprecedented opportunities in front of us, but we do want to take just a quick pause to think, okay, how do we now collaborate in the most constructive way possible, where everybody has a seat at the table that has real expertise and real resources to bring to the table, and that can help realize interoperable solutions across a care continuum. So while healthcare is largely paid for a lot of the work that's been done to date for health information exchange and for, maybe not MyHIN has a unique history that I've been part of in part in my past, an outstanding leader in the space. But largely speaking, it's health plans and health systems that are funding a lot of referral solutions and not community-based organizations. So let's just take a pause and think, how do we work together to co-design interoperable solutions, but also the workflow and the role-based access, getting clarity on roles and responsibilities, and designing a system that's supported by your solutions, but that really leverages our existing workforce. It's really, really important for us to be able to do this in a way that we're being deliberate and collaborative, and building off of also the good health IT work that's been done. I mean, the Gravity Project has done amazing work in the last 4 to 5 years that you're all so well positioned to leverage now. And I know many of you have been part of that.
Yeah.
And so that's something to celebrate, right? We can just continue on, and you already have a lot of the working knowledge of what can be implemented through IGs. But we also just need to be disciplined in thinking, okay, well, my paying client is the large healthcare system or the health plan, but I really need to think about these community partners to be an integral part of this long-term solution, because they are on the front lines of meeting the needs. And
Thank
they
you.
need to be
Yeah.
sustainable solutions. And this all needs to happen sort of together, right? That it's not just a referral to nowhere or onto a wait list. And we know that there's been an increasing amount of concern being expressed that we could be building roads to nowhere. So we all want to figure this out together. And I think there's a lot of good intentions. It's great to see the pledge to show the commitment to interoperability. And I think we just want to keep in mind that this is first and foremost about the individuals we're serving. And ideally, we'd like to be able to sort of have a collective accountability for the social outcomes, right? That it's not just about referrals in and of themselves. It's about realizing connections to services and improvements in lives.
But Kelly, you're just going to have to come back, because we have to deal right now. Right now, we're just dealing with referrals, which we know are not it is not the answer, but it is one step in the right direction. And I'm really excited to hear from this community of practice, and also from our 211, our partners at Michigan 211, and our partners at MyBridges from MDHHS, so that everybody here can hear what their plans are for your concerns, for the community's concerns, for their payers' concerns, the hospital concerns, and of course, how they're going to be using technology to move things forward. So thank you, Kelly, for being here. Please stick around like forever. I am going to move this along, if you don't mind, to introduce, next slide, please, Kate, if you would. We are moving on. So we have two amazing facilitators here today. We are really lucky because Sarah Kyle from 211 and Crystal Corpy from MyBridges are really important leaders in this ecosystem. And in August, they were not part of the panel. And even today, they're not signers of the pledge, and they are not on the panel, but they are here to be with us. They work with us in a collaborative spirit, and so much so that they really wanted to be here and facilitate for us today and take you through your questions and take our vendors through their lenses of how they see their work changing our future. Sarah, let us know what you do. Tell us why you're here, will you? But do it fast, thanks.
I will promise I'll do it fast. I'm here because this is the work we want to do, right? We want to serve Michiganders better. And, talking about where does 211 fit in this space, I think I'm just honored to have this conversation and talk about what does it mean for us to be interoperable. So if we go to the next slide, 211 is interesting. And if you don't know exactly what we are, reach out to me and you'll get to have the best conversation in the world, because I'll go through all of that stuff. But for those of you who already know, let's add to that, right? So also thank you, Joanne and Myhin, for including us in these conversations and making sure that we are part of this ecosystem. So what you need to know, 211 is also available by text, chat, and online search. There's rarely an easier marketing tool than our 3-digit dialing code, because it's been around for 25 years. And although, as we talked about, technology is amazing, even the best technology needs access to people. And that's what your friendly neighborhood 211 also provides. We have a large staff of professionals, including social workers, navigators, resource managers, community health workers, all here to support Michiganders in getting folks access to very vital information. We also offer secure electronic access to our resource directory to many partner organizations. And we've built software that is agnostic. It's a hub, really hoping to be truly agnostic. The next slide. We also follow some national standards, and we actively curate and maintain a database with authentic local relationships. In Michigan, we have over 7,000 agencies in our database, with over 30,000 programs that we can send those who need help, or those who need to find places to volunteer or donate or the list goes on and on. In addition, those relationships are supported by the United Way brand, a nationally recognized leader in health and human services. Most of the 211 network in our country is supported in one way or connected to a United Way. And in Michigan, our Association of United Ways helps 211 every single day. In your next slide, you'll find some data. Man, we have some really cool data because of all of those touch points with humans. We can give you lots of information. Nationally, last year, we handled about 50,000 contacts a day. In Michigan last year, we took over 781,000 contacts or connections, and we made nearly 900,000 referrals. 211 publicly shares that community needs data, and we're a real-time barometer of health and human needs. Our partners, our United Ways, our stakeholders use our data to help determine resource allocation and service gaps. Most recently, my211.org/legislators was launched to help our policymakers look at each of their districts and really understand what the need is and what the unmet need is. What could we invest in? It boils down to we're here every single day to help every single Michigander, and we're proud of the work. We're proud to be here as your social care referral database. I hope you'll reach out anytime. And we are just so excited to work together. So Joanne, thank you for letting me be here. And we're so excited to be part of this conversation.
Super. Now the work. Crystal, tell us a little bit about MyBridges. Tell us why you're here and why you're so excited to be here. And then we're going to get on with introducing our panel and like really getting into it. We're ready. We're ready.
Great, and so excited to be here. Thank you. And following up with Sarah and I are so pleased to be part of this. As you mentioned, Joanne, we're just here in good faith. So with me, I'm with the Michigan Department of Health and Human Services. And as a department, MyBridges, we've expanded and thought about user experience and human-centered design with MyBridges. Yes, it's a government website. Yes, it helps individuals apply for benefits, but not only can it do that, it can also help and empower and uplift our Michigan residents in needs, or in their needs, I should say, in time of need. So with MyBridges, we've really gone out and looked at the human-centered design using 3 key stakeholders, thinking about our case specialists within the department, our Michigan residents in need, and then our community partners. We have an awesome opportunity with our partnership with Michigan 211. And with our referral information that we have, we are leveraging MyBridges partners who have registered as referral partners along with Michigan 211 information. So we're not, as they say, recreating the wheel. With MyBridges, I hope if any of you haven't used MyBridges, certainly take a look. If you've used MyBridges since 2018, I certainly hope that it looks drastically different for you as a Michigan resident. We offer, applying for benefits, looking for options for our partners, and our partners. Oh, thank you. Thank you. So with MyBridges, there's a few things that Michigan residents can do. They can apply for benefits, of course, using a paper application or MyBridges. With it, an individual also can identify needs using our Explore and Help Me Find resources and connect to organizations within their community. And as I mentioned, that's with our partnership with Michigan 211. I'm not sure if everyone knows this, but any and all Michigan residents can create a MyBridges account to locate resources in their community. It's not just for individuals who are receiving benefits or applying for benefits. So out there, if they're just looking for, I need help with daycare, we're, integrated with a Great Start to Quality. An individual also can help maintain their benefits, answer questions about their benefits 24/7 with MyBridges. So go ahead to the next slide, please. So we do have targeted features for My Bridges community partners that can help how to use My Bridges. They can help their clients completing renewals. So thinking about, as we're talking about referrals, we know that our community partners and organizations play a significant role in helping their clients or their neighbors in need, access to benefits and supports in their community. We have 3 types of partners. We have access partners, referral partners, and navigation partners. So hopefully, as people are thinking about what can I do to help my client, my resident, Michigan 211 along with My Bridges can certainly help. And we're excited to be invited and to be in this space where we're helping to empower and uplift Michigan residents. So thank you.
Thank you so much, Sarah and Crystal. And I am going to rely on you to keep this thing moving. Okay. But we are here now to introduce the stars of our show. And I have the biggest pleasure. And also, I just want to say I'm sorry to all of you for bugging you and for being all up in your business for so long. This is exactly what I wanted to happen. And now I'm going to stop. Just kidding. I will not ever stop. Chris Grace is here. He is the Chief Executive Officer and founder of Care Advisors. Care Advisors is a social care management company that addresses health disparities by developing a complete ecosystem for social care management. The platform supports interoperability amongst clinical and human services data, value-based payment models, and comprehensive automation of manual labor-intensive workflows for social care management. Thank you so much for being here, Chris. Next slide. We also have the Todd Bailey, Chief Operating Officer and co-founder of CareConvene. CareConvene believes healthcare should be about achieving one's full potential as an informed and empowered individual. Everyone should have the basics: health literacy, easy access to care, tools that provide health recommendations. As a result, digital healthcare interactions will become personal with a shared understanding of a patient's goal. CareConvene digital platform offers fully vertical solutions to help consumers and clinical teams build strong collaborative partnerships by balancing accessibility, convenience, optionality, and affordability. Thanks, Todd. Oh, Jaffer. Jaffer, how do you say your last name?
Trace.
I should have asked you before. Jaffer Trace is major. He is the Chief Operating Officer of Find Help, formerly known as Aunt Bertha. It's sort of like Prince. Find Help is the nation's leading social care network, making it easy for customers in a wide range of sectors integrate into social care and integrate social care into the work they do, from education and government to housing, healthcare, and more. Through customer platforms and their public site, findhelp.org, the Find Help network reaches more than 13 million users, probably more now across the country, making it easy for people to connect to help and the verified social care providers that serve them with dignity and with ease. Thank you so much for being here, Jaffer. Shannon is the Director of Value Realization. I think I need to take that title on, I gotta say, for Holon. Holon's patented sensory technology curates multi-source patients and member information and automatically presents it directly within clinical workflows, saving healthcare teams time and relieving the everyday distractions and barriers to delivering healthcare quality. Holon leads with innovation to create tools and services that deliver operational relief to care teams who serve us all, producing both a business and a human return on investment, proving the value of business and human ROI. Thank you, Shannon. I know you've been really busy traveling. Jeff Chang, PCE Systems, our homeboy here from Farmington Hills, Michigan. He is an information technology and services company specializing in custom hosted solutions that go beyond the capabilities of off-the-shelf software. PCE provides comprehensive integrated information systems for a variety of community-based behavioral health and social health organizations. PCE underlies one of our Michigan shires, the Washtenaw Shire, and they seek to break the mold of typical software vendors by providing innovative solutions and unparalleled support services under a model that engenders trust and collaboration. with the ultimate goal of helping clients provide the best and most efficient care and services to the individuals they serve. Jeff Chang, thank you so much for being here. Bob Fike. Bob Fike is the Chief Executive Officer from Riverstar. I think I bothered him more than anybody here, so I'm super sorry, Bob. Riverstar partners with service organizations, healthcare providers, funders, and payers to deliver solutions for community-based whole person population healthcare to address social determinant and behavioral health needs. Riverstar also underlies one of our Michigan shires, the Jackson Shire. This collaborative approach leverages and integrates with existing community pathways, including health practice record systems to facilitate care coordination among providers while empowering individuals to actively participate in their own care. Riverstar's whole person care platform also offers revenue opportunities to foster sustainability. And finally, Caitlin Manzano from WellSky. WellSky is a technology company leading the movement for intelligent, coordinated care worldwide. Their next level software, analytics, and services power better outcomes and lower costs for stakeholders across the health and community care continuum. WellSky helps providers, payers, health systems, and community organizations solve tough challenges, improve collaboration for growth, and harness the power of data analytics and achieve better outcomes by further connecting clinical and social care. So if everybody wants to come off mute, no, don't come off mute, but I think it would be really amazing if we could just give everybody a round of applause. Guys, imagine if Epic and Cerner and Oracle and Meditech and all those EHRs decided to sit down at the beginning of this digital transformation in 2009 and come together and say, hold up, I know that we've all got business. I know that there's a lot of money to be made, but how do we do it so that we are putting people first? How do we put people before profit? This is what is happening here. I feel so, so proud, and I want to give the panelists every minute to talk about how they see this world. So Sarah, over to you to sort of manage how we move through the rest of you and Crystal, to manage how we move through the rest of the panel today. Guys,
Is anyone else excited about Joanne's energy? It's it's amazing.
I swear I dreamed this. I have been dreaming about this. I really have to get a life, but this is
at 4 o'clock on a Thursday, girl. You make us look bad. I need to get moving. So well, let's start. Let's jump into it. Let's talk about the evolution of care infrastructure. The digitization of social care data. This is a really important. And Chris from Care Advisors, would you mind starting that discussion? What does that look like? Commenting. Then Jaffer, would you mind also commenting on that?
Yeah, no, that'd be great. Thanks so much, Sarah. Again, I'm Christopher Grace from Care Advisors. What I think would be helpful is maybe laying out a little bit of the landscape on what we've seen in trends in digitization of the technology that enables social care management. And I think Joanne did a great job of highlighting some of the origin story behind MyHin. But what I'd like to do is maybe take the journey a little bit pre MyHin, looking back 40 years, and then seeing the phases that you've seen that brings us to today, and where are we at with digitization around social care data. And when we think about social care data, I break it into really two major components. You need clinical data, because this is oftentimes a collaboration between social services and healthcare data, and then human services data. On the clinical side, physician notes, diagnosis information, care plans, medication lists, imaging and test results. Human services data, that's been mentioned, social service needs data, referral information, program eligibility, social service interventions and utilization information. And thinking back, to the early 80s, you had that foundation of Epic and Cerner just being founded, right? The nascent days of bringing in new tech, and you can feel the 80s vibe of, those really old databases being built. And from that point, really to 2008, you had just a nascent industry where there was just adoption in technology for what had already been established in the real world for hard data that was kept on paper. There wasn't a lot of establishment of standards for interoperability and data sharing. And even looking to 2008, the adoption levels for EHR data was about, 5 to 10%. Getting into hospital adoption, and then a little bit higher for individual practices. And then in 2008, you really had a watershed moment, right? You had a new administration that came in where the priority was healthcare. And you had massive investment from the Office of National Coordination, or ONC, that put out $500,000 across 50 states for the establishment of HIE investment, which created institutions like MyHIN. It also, we work nationally, created a lot of new institutions that didn't survive, that weren't as adept at creating sustainable models as you have in Michigan. And real applause to the team at MyHIN for working through those formative phases and how you bring individuals together successfully, and being a survivor in that model. You also had the Affordable Care Act that made substantial investments for adoption of electronic health record technology. And you saw going from 10% adoption up to about 80% by 2014 with those subsidies. And at the same time, you saw a movement for human services data investment. You had the creation of CMMI that was investing in models. You had companies that were founded that were specifically focused on sharing human services data.
Right.
You had additional acceleration for a lot of homegrown registries. And that was a huge boon to bringing data together. But
and some of that movement has been big, and I'm not trying to cut you off. We're trying to get a lot going, so they've made me the bad guy.
No problem, no problem there.
But Jopper, do you have a comment that you can bring in? Seeing, adding on to what Christopher has talked about.
Yeah, just a bit. So, and he's right. We've come a long way, from the first two FQHCs, doing community care in the 60s to big digitization. And, just to call out, so many health systems that use Epic, for example, they had a business plan in 1979 that explicitly said digitization, in social care, which is fascinating to think about. But regulations and things like a pandemic can really get in the way, but can also drive prioritization. So it's true, in the last 5 years, we've seen a massive uptick in digitization in social care to the tunes of hundreds of thousands of social care referrals that have good quality information within them. And to what Kelly articulated earlier, it's going to come down to, consistent collaboration with everyone at the table. The good news is there's no shortage of innovation, in the private sector, from the interoperability pilots to, the Michigan Pledge work to, new Z codes that we're seeing mature. All of this is helping, to bring more people to the table. And can't say enough about the coordinating entities like the United Ways and the 2-in-1s that, are really foundations and communities of this work, for so long. But there's more wind coming, policy wind, and, even state RFPs, where the ask is to accelerate, this digitization. One thing I'd share is infrastructure when it comes to really understanding true disparities and improving, addressing those disparities is going to require policy changes. And we can make information as digital as ever, but we've still got to address policy disparities along the way. So that's a couple of additions.
That's great. Thank you so much, both of you, for your thorough answers and this excitement of this continued discussion. So thinking about clarifying the goal of cross-sector data sharing, Todd with CareConvene, do you have anything you'd like to share with us about that?
Yes, certainly. Good afternoon, everybody. Todd Bailey from CareConvene, and I do apologize for not being video ready today. I'm still on family holiday out of the country, so the connectivity is not
good
that
though.
good.
You got a good picture. We're
well,
okay.
thank you, and I do appreciate that introduction, Joanne. So thank you. Yeah, Care Convene, interoperability, data sharing is very vital to Care Convene, and we understand it to be very vital to the industry. Basically, Care Convene started to try to solve the problem of to make it easier for patients to navigate the health system. And obviously, Care Convene being a patient-facing and provider-facing application, you can imagine we consume a lot of data, we generate a lot of data, and we need to share a lot of data. So the technical aspects of interoperability are important, and thankfully we have a really talented team working on that. But also is for the front end, the user experience, the customer experience with how data is used within an application. One example of some of the work we've done, Care Convene has worked with the Interoperability Institute, aligned with MyHIN and Velatura. And that was a project that built out patient access, where patients could log into their payers, their insurance, whether it be whatever payer there's out there, and be able to download their data. And that was a kind of a cutting edge, really good project that we did.
Was that
And then
considered, would you consider that cross-sector data exchange, Todd?
Yeah, definitely. Because as we know, people change jobs. They could have multiple insurers, medical insurers. So for the ability for the patient to log into one or more of their insurers, whether it's present or past, and get the data, bring it into a source, and then also once they have that, to be able to share it to their provider, a health system, or whatever, CBO. I think that's a vital way, a vital power to give patients. And again, that's something that's been part of Care Convene's philosophy and strategy from the beginning. One thing also, Care Convene, we've been very fortunate to have MyHIN as such a great business partner, because we've been the past, I think, year or so sharing SDOH data with MyHIN. So I know that's just kind of a new thing that's still evolving, but we're happy to be part of that effort. And really, Care Convene wants to be part of the whole community, the community that's trying to solve this problem of interoperability.
Thank you so much for that, Todd.
You're
How
welcome.
about Shannon with Holland Solutions? Do you have anything you'd like to talk about with goals of cross-sector data exchange?
Absolutely. And my background comes from having been the person in the practice seeking out information that is siloed in systems, and certainly working in Michigan PHOs where we spanned different entities and again faced those silos, whether in the medical realm or in the community-based organizations. Now, certainly I'm here representing Holland Solutions, and our platform is more well known as Referrals Plus within the community. And that is focused on the providers and the community-based organizations and enabling that data sharing. So certainly we're supportive of sharing that, because we want to help break down those silos, but also we're very focused on removing that administrative burden for those care team members, for those staff in those practices and CBOs that traditionally have to seek out this information. We like to use the term portalitis, but there's a different place to go for everything that you need, a different portal, a different report that you have to access. And oh, that's last week's report. That's no longer relevant, right? We've all experienced where this information is housed in different areas, and it's necessary to provide care to the entire patient. A perfect example in the community-based organization side, addressing those social determinants of health, or enabling the patient to have access to their medical care, enabling that access to have good nutrition so that you can help manage your chronic diseases and so forth. I mean, a couple examples of where information exists on both sides, but without that cross-sector data exchange and what we are looking to help provide in the referral space, how is that information gathered? Well, you pick up the phone, you use the fax machine, you might cross your fingers and hold your breath, hoping it's the right username to get into that portal to find this information. And so what we are building here with this program, and certainly why these vendors are coming together, we want to help reduce that burden for those providers and care teams on the medical side, as well as the staff in those community-based organizations, to share this information, but ultimately at the benefit of the patient. Care cannot be improved without coordination among these different entities. And until we can remove those silos and really enable that data exchange in order to have information at the right place in the right time, we cannot take care of the whole person's care. And so we as Holon are very excited to be here and to be supporting this, and also very much appreciate the work of all the vendors involved to break down the lines between our companies per se and to enable whole person care spanning across the medical and the community-based organization entities.
Shannon, that leads us perfectly into the very next piece. And I would love to hear more. And I think I said you hit right on is the value of interoperable referrals, right? Referrals is the world we live in, but we want to do this together. So I'm wondering, Bob, from Riverstar, if you don't mind jumping us off, what's the value of interoperable? Man, it's late on a Thursday. Joanne, I need some of your energy. Bob, do you mind commenting?
Sure, appreciate it, and that does provide a really good lead into the whole discussion. From our perspective, the value of interoperable referrals is really improved care coordination and better service for the clients. I mean, that's what it comes down to. It adds other things to it, improved processes, less stress for the workers in the practices, in the CBOs, makes their life easier. But fundamentally, it's better care coordination and better service for our clients. CBOs, practices, the whole healthcare systems all have their own internal systems. Some are happy to work inside of the care hub and do their work there. It fits in without disrupting their environment, so it works well. Others have really robust systems in place, and they do all their work inside their own internal systems. Asking them to work from another system is really disruptive. So using interoperable referrals lets them work in their system and pass the referrals, the first level referral screenings, to the care hub. We take it from there, do the assessments and so on, using navigators from 211, using other community navigators, and get people connected to the resources. That lets the agencies with the systems work in their own environment and streamline their processes. Either way, whether it's working inside our system and sharing data back and forth using interoperable referrals, or working inside a native system and sharing referrals, having that interoperability improves the workflows internally, improves care coordination, and improves the service for the clients. And that's where it drives.
Thank you, Bob. That is wonderfully said. Jeff from PCE, do you mind commenting as well?
Yeah. So Shannon, I think you need to go quickly and copyright that portal.
It's done. We just trademarked it. Sorry.
Looking at the chat, there's a lot of excitement about it, including on my end. Bob kind of referenced this, but and I think you do too. I think that really one of the biggest values of having this concept of interoperable referrals is it lets everyone hopefully stay in the systems that they have chosen to use, either their case management system, or they may be a CBO who is using, Find Help or another platform. And it also lets us leverage the comprehensive networks that these organizations have created and expand those networks so that they're not closed networks, but they're open networks, so that a particular individual with a particular need can get the best services to meet their need that's possible. This group, the community of practice that we've created, I believe that all of us have some really, really good platforms and really, really great software. And so we're able to, I think doing this is value and leverage and honor the strength of the platforms that have already been built, and the CBO's right to choose what platforms they want to be on, be it a large network like Care Convene or Find Help, or a case management system that they have chosen. But it's a way of doing that without punishing them and saying, well, you have to choose this because this is the platform in this particular environment, or this is the platform that will give you access to regional referrals. By creating these interoperable referral platform, we're giving us an opportunity to actually to let CBOs choose where they need to be. And I think that there's a couple of additional things that happen because so many CBOs right now are really just in the processes of adopting case management software and software, of their own. If we build this right as a community of practice, we're setting a standard and a framework so that as those platforms get adopted by the CBOs know what to look out for, right? If they're going to choose a piece of software, they're going to choose a piece of software that they know has some ability to do this interoperable referral. And that really lets us get in at the ground level and start right, as opposed to what Chris Grace was saying at the very beginning, having these old, antiquated, siloed EHRs that were never built to share information with each other. So I think there's a lot of value, and I'm excited to be a part of this.
Yeah, and starting off right, that's the way we need to do it here in Michigan. Let's lead this. Caitlin. Yeah, hey, Caitlin, WellSky, any comments?
Hi, sure. Hi, everyone. Caitlin Manzano with WellSky. Of course, my colleagues here have said what we're all thinking, and we share so much of the same goals, which is why we're all here. I will add that there is the benefit for the individual that's receiving the referral. I think when things are made on their behalf and we have a CBO ready to reach out to them directly, I think that takes a big burden off the individual. I was at the RISE SDOH conference this weekend, and the gentleman from US Hunger said, we talk about barriers all the time, but the biggest one is shame, barriers to access, and the biggest one is shame. So sometimes when there can be this system where people are communicating and the care provider, the social care provider can reach out directly to that person, that can eliminate a lot of the go-between or the reasons that individuals don't reach out. Aside from, if I'm facing hunger and I'm trying to get home, I have an 11-month-old baby and I'm trying to get home to him, the sticky note that I tried to write down that food bank on is out my window already. So if I know that someone will call me directly because the referral has been made on my behalf, I think that's a big benefit to this work. And I'll add a little bit. I know this isn't on the agenda, so we can talk offline, but there's some conversation I see in the chat around bi-directional referrals. And that's another big piece of why we do this, that we know we can go back and forth in our social care coordination platform, and we can have the CBO that's been referred to by the health plan respond and say, hey, I was able to get Caitlin some food, or I was able to connect Caitlin with this housing resource. So a big piece of it there as well.
So look, we had all of these. So a lot of you wrote in questions, and we were planning on getting to all of them. And now, of course, we don't have, I'm like worried about time. I think we should all plan to have a sleepover. No, I'm just kidding. But so we have these questions and they have come in, and I'm just wondering, like, Lisa, how do you think we should do this? I feel like if you really want your question answered, I'm so sorry, like, come on camera and start talking to these people who are here to answer, specifically to be here in front of you. Like, fight for your right to get your answer. In fact, we just had somebody from Pathways Community Hub. He's really interested in these closed loop referral like statistics.
Rick, jump in.
Do it.
I'm off mute.
Take your time, man. Now is your time, everyone.
Ask
Let's get
question.
to it.
Yeah, so, well, really the question is, I hear the talk about closed loop referrals, and I'm curious to hear what kind of rates of closed loop referrals communities are experiencing. I think the vendors, I'm not sure if that's proprietary or not, it'd be nice to be shared, but I think in the end, it comes down to what are the communities experiencing? So I'm curious to hear if anybody's willing to share that. Thank you.
And I can go ahead and kick us off. This is Shannon from Holon. So I did a bit of research, and not specific to any particular vendor, but more broadly. And just at a general perspective across referrals in total, Institute for Healthcare Improvement reports that up to 50% of referrals are not completed, or that loop not being closed. Now, of course, with the addition of a platform that helps enable that bidirectional exchange, the closed loop referral rate on average increases to about 73% per the Transforming Clinical Practice Initiative. Now, I'm more than happy to share for Holon, as we looked at our 2022 referrals from the medical entities between community-based organizations and back and forth, our closed loop referral rate was 70% for those organizations. Now, the average when it comes to community-based organizations in my research, again from Transforming Clinical Practice Initiative, was closer to 17%, because in many cases, those community-based organizations are not leveraging a platform. And of course, that's going to vary depending on if they do leverage a platform. I certainly cannot speak to our other vendors, but if anything, I can confirm that using the technology to enable that bidirectional interchange really has an impact, whether it's medical to medical referral or medical to CBO and back and forth from there.
And this is Jaffer. I'm happy to add a little bit more color. Given our work with more than 350 large healthcare entities across the country, we see, and I'm looking at my other screen here, 96%, 90%, 84%, 93%. What it really depends on, though, is whether or not they have a strong relationship in partnership with the organizations that they're involving in their closed loop network. And so it's one thing to refer to a food pantry that stays anonymous and never wants to give you information, which is okay, and to get information back from a utility assistance organization that you have an MOU with that's committed to reply 100% of the time. So that trust building is essential, and we see very high percentages. We also see those in the middle. It really depends on, is the partnership, aligned much of the time.
Yeah, I can share as well. We're at those numbers too, specifically with our accountable networks, which is organizations that join us and share our commitment in responding to the referrals. So we're at the same rate. I will share too. I don't know, Joanne, I might be cheating, but it came up in the chat and it's on this slide around consideration around resources for.
I'll allow it. I'll allow
it. Now we're at 4:30 on a Thursday before, for some of us, a holiday weekend. So I'm going in. But there was a comment here around when CBOs are reimbursed for their services, there's an increase in response, right? And we are piloting based on feedback from our community-based organizations. There's so many portals, there's so many platforms, and this takes time for people that are already really busy. So we're piloting in Michigan and Ohio a funding model where joining us in our work and in our network, we have an onboarding grant that offers some funding for organizations that join, and then a small amount per referral per referral responded to, because we know if there's energy into the system, into the technology, then people are more apt to use it. And so we're trying to up just the engagement for responding to the referral, even if it's to say, sorry, this person doesn't qualify. Of course, we want people to receive services. That's why all of us are here, right? But sometimes that gets lost as well if there's we don't have that information, right? Someone was referred and they just don't qualify. And then again, they're kind of out there looking for what's next. So we're piloting again here and in Ohio, some funding for this. And we know it doesn't compensate fully the, I'm assuming I'm a social worker. This is my first kind of enter into this work, but I've done the work in community organizations for a while. And so I'm assuming that some of the funding, particularly for responding to referrals, doesn't cover the cost of service. But we also know that there's some referrals, it can take a few minutes to look through that, and some are a longer length of time. So what we're piloting is, does this incentive allow people to use this tool to boost what they're already doing really well? And does it help? And does it matter?
So if people are able to use this tool, Bob, would you comment on how are patients going to have access to their data?
So from our perspective, the way we work, and I'll talk about Jackson specifically as an example, but the way we work is we gather the SDOH data from a screening. We could do the referral, and we push the data back into Epic so that it gets into Epic, it gets into the patient health record, and the patient can then use their portal to get into their health record, and their information is there. We generally don't store health data in a care hub because the CBOs generally don't need it to deliver their services. We use interoperable referral data to pull some level of health data, diabetic, chair-bound, things like that, that are critical to being able to deliver the service. And then we push the results back into Epic along with the status changes so that that information is kept in the in the health system, and it's in one place. We don't want to store fundamental health data in the care hub. It just doesn't make any sense from a PHI protection perspective.
So Jen Murray, you had kind of a comment in there. Do you want to jump on and kind of talk about that for a minute? Because I think
Jen
that this
Murray,
relates to it.
Yeah, Jen Murray, you're killing it in the chat, by the way. Like, let's do it, Jen Murray. Let's see ya.
Okay, sorry guys, I was in the chat and then I had to, because I'm on my phone, sorry. Yeah, I really feel that a lot of this data sharing and community-based organization partnership and understanding needs to happen on a regional level. We know who our CBOs are. We know we do refer back and forth. A lot of it is manual. But I do think some of this data sharing really and planning needs to be supported financially. I would suggest through Shires, those same models, and be able to come up with a regional solution for the interoperable referral piece. The second comment I made was just the patient consent language. We've been, kind of waiting for some recommendations around patient consent, because if we don't have good patient consent language, we really shouldn't be sharing, the SDOH data. So just wondering where we were as a state as far as that goes. Thank you.
Does anybody want to, look, has consent come up when you guys meet every Friday for the past 700 years? Has consent come up there at all? Have you guys even thought about that, or?
I think it was mentioned once or twice.
Has it been mentioned once or twice?
Yes, there's a lot of work on the consent stuff, and I mean both within our community practice and at the national level, there's stuff going on proper consent and how you gain it, and we're trying to work towards that, because the comment was right. I mean, we need to get the consent stuff right, and that's something we're all trying to work together on to find a way that works.
And
I'll let some of the others comment on that.
I think that the best thing that I can say, at least at this point, is that it is top of mind, and that in the conversations that we have had, you have a lot of people who are very sensitive to both the legal compliance component to it, as well as the impact to the individual receiving services. And so there's been a lot of discussion. MyHIN has offered a lot of input through Shreya, I don't remember her title, but she's one of their lawyers. And we have had, lawyers and compliance folks and all of that. I think the consensus is that we've got to get the consent right or this all falls apart. Where we're still working on getting consensus is exactly how do we do that. I think we've done a great job with that on the behavioral health side of things here in the state of Michigan, for those of you who don't know, with the standardized consent. And so we're trying to leverage what is working in a way that we can translate that over to social cares. But what's even more interesting about it, and I'm going to open the can of worms and then I'm just going to leave it on the table, is when we talk about consent, we talk about behavioral health, or we talk about HIPAA, and we talk about all of these things. We are talking about healthcare information. And sharing of information between covered entities or Part 2 programs or agencies that are structured, under HIPAA and these other regulations to have to protect this information. When we talk about social care information, the world sort of opens up. They're not HIPAA covered entities. And so some of these assumptions that we're making on the healthcare side cannot be applied to the social care side with CBOs. And so that just means we need to be even more thoughtful and intentional about how we apply this and what the rules of the road are going to be to the CBOs that may be receiving healthcare information but aren't covered entities and don't really, they're the agencies that spell HIPAA, HIPPA, right? They know about it, but they don't really know what it is. So there's a very large conversation that's happening about that. And I don't want to get too far into it, but it's complex and it is being addressed.
That's beautiful. Christopher, would you mind addressing the question that was asked by Henry Ford Health? What new referral locations would be available using this kind of work that we're doing?
Yeah, no, I thought that was a really interesting question. And I wouldn't think about it just merely around geographic locations, but I do think there would be expansion throughout the state. But I think about it as the richness or robustness of data. I think if you're a provider today, you'll probably have some referral tool. You'll probably be able to get some data back for a referral for maternal child health or older adults, or a referral at discharge. But the challenges I think that we've all heard about, and part of the community practice, is the completeness of that data. Are we just getting a referral notification back, or are you getting indications around social needs for a population before they come into your emergency department? Are you getting information on social service utilization after, or are you just getting a complete referral? I think that's an important transformation. And then more complete data. I think, there are data silos when you break down the Michigan landscape just on the social service side. You have human services data that's largely controlled by the state with eligibility systems. You have referral platforms, being able to unify that so you get full insights and a true longitudinal record where you can bring together clinical and human services data. That's really the vision for, I think, the practice here.
That's great. And I think that brings us then next to our question from Melissa Gary with Great Lakes Physicians Organizations, siloed CIEs. How will they be able to interface? So with that, Todd, would you like to take that question?
Definitely. Thank you. In terms of interfacing or data sharing, obviously there's the technical piece, which I think all of us can figure that out pretty easily. But I think it goes back to consent. Setting a standard, agreeing on a standard so that patients' data can be protected, the privacy of it. And I think that on another level, that just allows the process side of all this to work a lot better. If we can all come to a standard, if we can use that standard, the data would seem to flow a lot better. Patients know when and where their data is going. And the receiving party knows it's coming from a valid source. And again, we're we're in this together with everybody. We don't have it all figured out. We're trying to blaze down that path independently and also within the group here. So again, it'd be interesting to come back in a few months or a year and just kind of see where this has progressed.
Yeah, I like that. So let's talk about sharing information between CBOs. Joffrey, do you have any comments to add to this?
Making the assumption that there are more standards, meaning ways to codify what we're sharing with each other, and semantics, meaning ways to understand what we're sharing with each other. When is help pay for food different from a food delivery versus a money for food? And then we can focus on the what is being shared. And I think most of us agree that strengthening the care coordination can improve overall health of the person being served when information is going between CBOs and healthcare. But we need to be mindful again that some behavioral health service providers or other assist providers are incentivized to share that information back with healthcare. But there may be domestic violence organizations that serve people, or food pantries where their entire mission is around protecting the dignity and privacy of that individual. And industry shouldn't go into those conversations saying, please give me everything you have, without understanding how they're supporting community. And it might be the wrong thing to do to overshare unless that person intentionally is ready or understands the implications for their overall health by sharing that information to support their eligibility for housing placement or potentially other services. So again, we have to build those relationships by listening within the community, not by imposing a regulation for the sake of industry. So I think that's a key part of improving the information sharing.
It's such good work, guys. And there are so many questions in the chat. I don't have the energy that Joanne has to catch them all. So this is your time to jump on, take yourself off mute. Let us know what questions you might have, because we are here, right? We have some industry experts. So please feel free to jump right in.
Is Dina here? Dina Smith?
I'm here. She was here.
Ask your question.
Yeah,
It's a
ask
good
your
one.
question.
Well, I thought there was a little bit answered, but yeah, I'll be happy to ask it again. So my question, you can see on there, is asking about considerations for resources supporting CBOs who are being asked to use multiple platforms. So I heard the person from WellSky sort of talk about their piloting that they're doing. I guess just a little context around this question is that I think that there's so many, it's noise. It's a lot of noise. There's so many platforms and tools that can be used. And I believe in their ability to be helpful, but there's, from a CBO's perspective, there's too many. And there doesn't appear to be a plan. And that's what I'm kind of asking about, is how do these CBOs manage all of the different platforms and tools that they are being asked to use, but also there's the issue of updating their information. Like, I have yet to hear from anybody that the vendor is taking on that responsibility. I have only heard that they will call the CBO or email them and say, hey, it's time to update your information. And that could be a full-time job, just updating their information. And what I also don't think is kind of being taken into consideration is that most of these CBOs, they're not getting paid for these services. They are using grant funding, philanthropy, and maybe some public funding, but that's not that much. And so, to actually even update their information in order for them to get more clients when they are already maxed at their capacity and don't have enough resources for what they're already doing. So my question's kind of big, like what's anybody going to do about that?
Yeah, and I just want to pipe in on this. I think it's so important. there are many organizations out there. 211 is one of them. We happen to have 40 people down the hall in my office that are called curators. And these are folks that are doing that work on behalf of the community. They're meeting with social workers. They're identifying what's changing in the community. They're going to housing authorities and learning about what the services are offered in the community. And there's a lot of people on the ground. Some vendors are taking on that responsibility, but again, it's unfunded, meaning that's a complete, budget line item that we fund on our own. 211s, they've been doing it for years and years, kind of funding this as much on their own too. That's not going to be enough, I think, in the long term, meaning we're going to have to figure out how we aggregate this information without adding burden. And some states have talked about this as being a public asset, in the long run. So that's something to consider. I think part of the pledge is focused on interoperability, meaning if I'm a CBO and I use Salesforce and I just want all the referrals from 5 vendors, 10 vendors, doesn't matter, to all come to me in my own system, that's a beautiful thing. And that's what ONC is setting the stage for in their regulation. And they shouldn't have to worry about how many organizations are operating out there as vendors, because they keep doing their workflow with their terms. And they don't have to sign any special contract that forces them to give up the rights to privacy of the people they're serving. Those are the kinds of debates and discussions we're having, I think, in the group, which are really healthy, and I think are bringing to the top the principles, that we all want to follow in the future of this work. So I just wanted to share that those are important topics that we are tackling.
And
I think that's
Can I clarify one thing that I'm not sure if you said this, but I believe that it still is a requirement of the CBO to update 211. And it kind of made it sound like that wasn't the case. And so I don't know if I misunderstood or if I have information that's inaccurate today, because that was the case, that you had to update your information in 211.
So yeah, we are going to reach out to you at least minimally, because we follow national standards. We're going to reach out to you at least minimally once a year. If we don't hear from you, we can update your information based on, researching your website. But our intention is to do that individually, right, with a personal connection. So the 25 or more database curators we have here in Michigan are doing their best to make sure that information is up to date. And you're right, there are this could be a little, not a little, updating information is time consuming. Like I said, 25 people in Michigan full-time, and we're adding more as we speak because this information is complex. But one, I think, really good model that we have had is with MyBridges. And I can't speak for Crystal, but I'll say, you don't update MyBridges, right? They're pulling data from that one single, the resource directory in Michigan, which is 211. So Crystal, if you have any comment on that, we've reduced that duplication because you just do one source. And again, even with, I would say, some of our other partnerships, you get to update us, and that API, that connection, all the technical stuff Sarah doesn't get into happens in that magical place. So Crystal?
Absolutely. Thank you. That's perfect. We think of it as a partnership, and with it, 211 is doing this work. So as a state entity, there was no reason for us, as we say, to recreate the wheel. So we're helping also in MyBridges, where a community partner or a resident, if they notice that information is incorrect, they can send a message to Michigan 211 saying, hey, hours at this organization have changed, that type of thing. And we also, as an entity, remind our community partners to make sure that their information is correct. But I guess more to Sarah's point, as a state, do we need to have many people doing the same type of work? And that's why we've relied on the information that's in Michigan 211. It's robust, it's accurate, and it's a trusted name for us to partner with.
Yeah, I kind of also just want to jump in really quick, and I think you bring up a really good point. And part of the reason why we wanted to be a part of this panel and start this conversation is to get the kind of feedback that you're saying. And I think that you're hitting on something that we need to address as a community of practice. I think the ideal, and I'm not naive enough to really believe what I'm about to say, I think the technical people and the ideal here is that you won't you won't have to update it in multiple places because you can just choose the one that you like. You guys love Find Help because they will do the updating for you and they do all that kind of management for you and all of that stuff. You don't have to live in multiple distinct platforms like Matt Bishop was saying, in the chat here. You aren't going to have to live in those multiple distinct platforms. But I think that if I'm bringing myself in reality and being honest with myself, I think that is still going to be a problem. Even, I don't think that we're going to get to that ideal world where you're just going to be able to choose your platform and then you'll never have to use any other platform ever again. It's just never going to happen. So I think that's a problem that needs to be solved. And I think that's an important question for us to be asking and addressing when we are looking at building this sort of concept of what we're trying to do here. So I just wanted to mention, I don't think that it's a problem that's solved. And I think in humbleness, it's important for us to recognize that it hasn't been solved, but it is a problem that needs to be addressed.
We have 2 minutes left. There's one question that we didn't get into because it's really getting into the weeds, but I want to get into it really quick. A lot of people have been asking about how the community of practice has been thinking about patient matching. One of the things that Health Information Exchange has been, is supposed to be doing is mapping all of this disparate information to the correct person and the authorized people on their care team who are allowed to have this information. Has the community of practice talked about how they're going to patient match?
So I think that so far in our conversations, in the limited scope of talking about referrals, we almost don't have to address the patient matching problem, at least in what we're trying to do here. Because really what we need to do is match provider or organization or agency to agency, right? It's the provider directory issue. Whether or not the John Doe that I'm referring is the John Doe that as a recipient of the referral is sort of the endpoints decision. And so as of right now, I don't think we've talked a lot about the patient matching. Now, I can imagine that, for example, MyHIN, as a referral maybe goes through MyHIN, maybe MyHIN will do common key and put a common key onto it. I don't think we've gotten that far, but as of right now, it isn't, hey, I am sending a referral that is patient-centric and that needs to be routed by some middleman to, based off of the patient. The patient is, this is going to be a horrible way of putting it, the patient is irrelevant. It is the destination, and that destination is defined by the provider directory of the directory of CBOs that are going to be receiving it. So I think that's kind of the model, at least the way that I've been thinking about it in our conversations. We haven't needed to address patient matching because that's an endpoint problem as opposed to a CIE problem.
I hope people understand that. I just feel like it really, to me, it just breaks down again how sorry, this is not going to solve the problem, guys. It is the first step in a long journey of doing this the right way. And this is just interoperable referrals. There is so much more good, hard work to come, but everybody here is interested. Everybody here is doing it for the right reason. Thank you for taking the last an hour and a half. And for our community of practice, thank you for taking every Friday to figure this out for the state of Michigan, for these CBOs, for these social service providers, for the interfaith organizations, for the refugees, for all of the people that really need help. It's really what should be happening. And I'm thrilled that this went down. Thank you, Sarah and Crystal, for you being here makes it make sense, I think. Lisa is the head of our cross-sector data sharing program. You should write all of your anything that we've said wrong goes straight to her, Lisa Nicolau at myhin.org. Everything that you loved about this, everything that you want to know, if you want to be connected, please write to me. Again, we will be sharing the slides. We'll share the chat. We'll be sharing more and more. Come back again.
Thank you for joining, folks.
Take care.
Bye, everyone. Thank you.
Take care. Thank you, guys.
Thank you.